Okay, so welcome everybody. Thank you for joining us today. Like I said, for our 36th ATS COVID-19 Critical Care Training Forum. Today's session is titled Delta in Children, What are the Risks? So I will be moderating the session. My name is Sushma. I'm at Emory University School of Medicine with Dr. Nirav Shah, who is at the University of Maryland School of Medicine. We have an amazing lineup of presenters here for you today. Catherine Alex Despotes at UNC School of Medicine, Jennifer Blumenthal at Boston Children's Hospital, and Stacey Leanne Peterson-Carmichael, who is at Wake Forest Baptist Health. So just to remind you all, some of you have been here before, but we have a number of additional sessions that we have recorded for you and are available for free on the ATS website. Like I said, we have 35 previous sessions. This is just a rundown of some of our more popular and latest ones. So if you want to find these sessions, you can search for ATS COVID Forum, or you can scan this QR code and that'll take you to the website. So I'll just give you a minute if you'd like to get that link as well. Finally, I would like to ask you all to please give us feedback. We tailor these sessions for your interest and what we think would be most relevant to you all. So please scan this code. We'll put the link in the chat as well once the session is over. Please give us feedback. Tell us what you would like to hear about. And we're happy to do those sessions that are most relevant to you. And finally, I would like to thank my co-chairs for the COVID Forum, Dr. Lori Crotty-Alexander, Nirav Shah, myself, and Varen Cowell, our team of trainees, and especially to all our ATS staff, without whom none of these sessions would be possible. So with that, I would like to end, and I'll transfer the mic to my co-chair, Dr. Shah.
Great, thank you, Sushma. This is, I think it's going to be an amazing session. We have a lineup of fantastic speakers. Dr. Cribbs has done a great job of recruiting faculty, and with the help of Dr. Peterson-Carmichael, who will get introduced in a little bit. But we have two folks that I want to introduce, and I want to particularly highlight kind of how extensive their training is, because I think we have a lot of expertise packed into our group of panelists today. So first, I'd like to introduce Dr. Alex Despotes, who is currently in her second year of combined adult pulmonary and critical care fellowship and pediatric pulmonary fellowship at the University of North Carolina at Chapel Hill. Her clinical and research interests include cystic fibrosis, primary ciliary dyskinesia, and non-CF bronchiectasis, as well as transitions from pediatric to adult care for patients with chronic lung diseases, and how to improve these sorts of transitions across the healthcare system in general. So as you can see from that introduction, and the fact that Alex is a Tar Heel, which I am as well, you can see that we're in for a real treat here. And then partnered with Dr. Despotes is Dr. Jenna Blumenthal. Dr. Blumenthal did her training at Boston Children's Hospital, where she did pediatric residency, and then also her fellowships in pediatric critical care, as well as pediatric infectious diseases. Her current position is a staff physician who's splitting her time between the PICU and the infectious disease services, and her research interests include antimicrobial stewardship and hospital-acquired infections in the critically ill and acute population. So without further ado, I want to pass on the forum to Dr. Despotes and Dr. Blumenthal to take us away.
Thank you so much. All righty, let me just get my slide shared here. Thank you for that nice introduction. Are you guys able to see the screen okay? Okay. So really excited to be here, listened to several of these early on in the pandemic, so it's exciting to be here. Quick couple shout outs to some folks who are very helpful in talking through different aspects of what's really broad topic, to say the least. So very appreciative of all the hard work and thought that's gone into this. And as far as bird's eye view of what we're hoping to cover, again, it's a very broad topic in a short period of time, but since we weren't exactly sure of the audience here, we thought we would highlight some of the differences in management of acute hypoxemic respiratory failure in the pediatric population and what we learned from the adult population, and then move outwards from the acuity within the hospital to some other important topics related to pediatric patients. So Dr. Blumenthal and I will be bouncing back and forth on some of these topics here. But I think a lot of us who have been working with patients in the pandemic have probably felt a lot of different emotions throughout this. We picked out a couple of different overlapping aspects of management of hypoxemic respiratory failure that may vary in pediatric patients versus adult patients. And so we'll try to hit on those, but I think a lot of the adult management stuff has been focused on in other sessions. We'll try to mostly spend time with some of our pediatric protocols. And then, as I mentioned, it has felt like we're sort of on a linear journey with COVID for a time, and now it's starting to feel like we're in this vicious cycle of Groundhog Day. And I think as we were reflecting on the different aspects of this talk, I think we all commented on, gosh, there's still so much we don't know. And so I think everyone who's on this realizes that we're still relying on a lot of each other's experiences from taking care of patients with COVID. And I think, honestly, our pediatric providers have more comfort operating in a relatively evidence-scarce zone because it's just so hard to study things in the pediatric population. But I think on the adult side, that was really unsettling for us at the start of the pandemic, and certainly something we're still dealing with. I think what it came down to for management on both sides is that we didn't know much about COVID, and we're certainly still learning, but we did know about ARDS management from non-COVID reasons. And so really sticking with the management, the basics of ARDS management on both sides has rung true as we were kind of comparing notes. And then we're incorporating new and emerging data. I think on the pediatric side, the concerns about what the recovery is going to look like down the road is really important, because these are patients who are going to have many more decades with potential lung injury, cardiac injury, whatever effects this virus has on the long run for them. So I think that's an ongoing big concern. And then I think we're all kind of experiencing that the end of the pandemic wasn't as close as it may have seemed earlier this year. And so that's been hard to deal with for everyone, but certainly continuing to do things like this is really helpful for that, I think, for all of us. So thank you guys for doing that. Just briefly, these were a couple of pre-intubation management topics that Dr. Blumenthal and I thought would be important to highlight that may differ between pediatric and adult patients. From a self-proning perspective on the adult side, I think we heard early on how beneficial it was for patients, and it's certainly sometimes hard to convince adults to lie on their belly and tolerate that. But certainly when you think about talking to a patient who is a pediatric patient, that's a really challenging discussion. So we wanted to highlight on that potentially being more challenging.
Yeah, Alex and I had had a discussion about this, and while it's fascinating, and we actually do put it on our pediatric algorithms at times, the reality is trying to get anyone below, let's say, 10 to self-prone would be almost impossible for any length of time, realistically speaking. Children are cooperative when they're feeling well at best sometimes, and when they're feeling unwell or feeling strangled by, a CPAP or a BiPAP, for example, they're very unlikely to be participatory in something like this.
Yeah, and again, that's something that's really helped some of our patients avoid intubation. So if that's not as easily in our arsenal for pediatric patients, it's sometimes putting folks in a tough position. One of the other things Dr. Blumenthal and I talked about is the role for high flow. And certainly that's been a mainstay of how we've tried to keep adults out of trouble, out of the ICU. And certainly our adult floors have gotten much more comfortable with escalating levels of high flow outside of the ICU. But where this sort of has been on the pediatric side, really a lot of the experiences from bronchiolitis management in much smaller patients and entirely different considerations.
Yeah, to jump in there. So exactly as Alex was saying, our high flow nasal cannula use has really skyrocketed, I would say, in the last 5 years. And even then, it's really only in that very young age population. So bronchiolitis is almost entirely seen in, I would say 2 and under, maybe 3 and under if you're being very generous, but mostly 2 and under. And we're getting much more comfortable with high flow nasal cannula there. There was a big study published in Pediatrics last year about where we're seeing high flow, for example, and it's about half of those patients are on the floor, and about half of those hospitals only see those patients in the ICU. So at Boston Children's, for example, we only see them in our step-up units or in the ICU. So that really limits, where we can use this therapy. And we're frankly just now getting more comfortable with high flow nasal cannula in the sort of bigger teen, more like adult physiologically like patients.
And Jenna's going to compare some different oxygen therapy algorithms in just a minute here, but again, coming at it from a totally different angle, just thinking of scaling something up that's typically dosed in pediatrics and sort of weight-based flow, essentially, which is very foreign on the adult side. So very much a different mindset for high flow. And then we'll also touch a little bit on timing of intubation. Again, all of the things we've mentioned so far are all really sort of ways to hopefully stave off needing to go down the intubation route. As I said, Jenna will go through some of these algorithms on the next couple slides, but highlighted a couple bullet points here. I feel like in the ICU, we've had this sort of pendulum that swung throughout the pandemic of early experiences recommending early intubation. Patients were so sick, concerns about aerosolization, especially with non-invasive positive pressure ventilation, and then transferring patients for safety, needing to be intubated, and then seeing how patients did on the ventilator and how sick they were and how long they were on the ventilator. Other considerations throughout the pandemic at times made us want to sort of delay intubation. And that's, I think, been a moving target for all of us and really hard to counsel patients and families on. And we had talked about patient experiences where you then have a parent in that discussion where you're making a recommendation for intubation and they're not totally on board with that. And it was a reminder to me of the extra layer of nuance that some of those discussions have in the pediatric world. But again, just some things to think about as Jenna goes through some of these algorithms on the next slide, and probably brings up a lot of discussions others on this forum have had with their own patients and potentially their patients' family members.
So I put this slide up with the essentially escalation of therapy in the setting of respiratory failure with COVID. This is from the covidprotocols.org, which is sort of managed generally by the Brigham here in Boston, but it's much broader than them, realistically speaking. And I think it's useful. This algorithm is not intended for you to read. If you want to read it, of course, it's available for free and everybody should look at it. It's great. But it's more so to say that they do sort of stick to adult and pediatrics on the same algorithm. And that's a great idea in theory. And a lot of the management is very similar, which Alex and I have talked about a lot in the last couple of days. But realistically, I think it's more interesting potentially to compare because I assume that the people on this call are sort of from all over the US, and your algorithms are probably very good. And every hospital very likely has one at this point in your ICU. But depending on what time of the pandemic they were made and, how frequently they're updated, it might be interesting as an exercise to look and compare them to these sort of algorithms that are updated on a very frequent basis. And I just wanted to point out that these exist, and we'll come back to a little bit of it in a minute. But on the next slide, to look more sort of specifically at the pediatric population, a colleague and I were asked by Current Opinion in Pediatrics to look at sort of how we want to deal. That we were asked to make an algorithm, which we didn't have yet, at least at my hospital, as far as how to manage COVID specifically in respiratory failure. And that the fact that we didn't have one was probably more of a marker of how infrequently we're seeing true respiratory failure in the setting of COVID. It's not that it never happens, it certainly does, but having a sort of specific algorithm for that hadn't existed yet. And so she and I sort of went to the old guidelines for ARDS, which is essentially what everybody has had the chance to do, and then tried to incorporate any sort of major findings from both the adult literature, because we're trying our best to follow you guys in suit, which is what we usually do, and then also to look at anything that has been published sort of in a rigorous way about COVID and pediatric respiratory failure. And so this is where we got. This was published in June. We looked at the PALIC criteria for pediatric ARDS and the estimate guidelines for COVID management, and we sort of made some recommendations, and lots of expert opinion here, to be fair, not mine, but many other people's as well. But essentially, very, very standard signs and symptoms of respiratory distress. But obviously in pediatrics, we're looking at the different age groups, and those are very widely, because an 18-year-old is really going to look like any adult that you guys are seeing, assuming they're otherwise healthy 18-year-old, as opposed to a neonate who is going to look incredibly different and can breathe very fast at baseline, and that maybe not be as big of a deal. But we're looking for changes in mental status, labored breathing, things like that. And then we sort of left it very vague, determined level of appropriate support based on mild, moderate, or severe from the prior guidelines. And we do write that you should consider high flow nasal cannula. And we put sort of a nod to the fact that it's pretty much first line therapy in the adults at this point. And we do write in there to consider self-proning with that, because obviously this does seem to work from the evidence that you all know better than I do. But again, that's really only going to work in compliant teenagers, and teenagers are not particularly compliant in general. And then after that, we talk about considering non-invasive positive pressure ventilation. And specifically, and I think this is maybe a nod more specifically to pediatrics, in the patients with coexistent asthma, because that was a lot of what we have seen in pediatrics. There's patients that are otherwise not previously healthy for whatever reason, and their COVID is commingling with whatever their previous disease is. And we are very comfortable managing pediatric asthma with non-invasive positive pressure ventilation. So thinking to try to encourage providers to go for their normal, just do what you know how to do very well, essentially, and put them on non-invasive positive pressure.
And so kind of putting all that information together, I think this is still an ongoing discussion of when you intubate patients, how difficult that assessment can be, how difficult it is to counsel families. I think one of the concerns that we've had when we were delaying intubation kind of as long as possible, letting patients not necessarily talk us out of it, but kind of wait it out. Let's see if we'll turn the corner. I think we had a lot of patients who were on non-invasive for a long time, not eating for several days, up to a week. They were actually kind of tiring themselves out, going into intubation then very weak. And they just seemed to do really poorly once they got intubated after being on positive pressure, non-invasive for a week. Again, of course, some people were able to skate by. And so it's just, I think, still really hard. And I think we can all think of examples of the person who did do okay. And then those times where it just really, they probably could have used more support sooner. Talking with other providers, things that others have found reassuring when trying to make that call. If they're comfortable on non-invasive, if it's not a struggle to keep them on it and they're kind of being able to rest on it, that's usually a sign that you have a little bit of time to kind of see where their clinical trajectory goes, get a little bit more data. And if they're stable enough to take a couple of breaks on high flow, to eat something, to rest, that's, again, typically a sign you maybe have a little bit more time, but it is a really hard call, and certainly an ongoing discussion with patient and families.
And then I think we all have reached the point that we all know that there are some patients that don't give you that sort of choice any longer, whether or not you've been skirting by for a couple of days and now you've reached that 7-day mark and you're hyperinflammatory and you can't sort of escape being intubated any longer, or if they came in crashing and burning and you're intubating them up front. I think looking at these sort of emergency signs are very similar in pediatrics and in adult medicine, from my perspective, but Alex certainly has the dual perspective better. But essentially, if you are truly not exchanging gas in either way, then that's not going to work for you. The acidosis piece, I think, is maybe a little bit different in pediatrics and adult medicine. Children, pediatric hearts, we like to say, take a joke a little better most of the time. So you can let them get a tiny bit more acidotic than an adult, and you'll see that in our suggested algorithm. But reduced levels of consciousness can be very difficult to assess in pediatrics as well. I will say that, many of the patients that we see are not sort of this category of previously well child that's all of a sudden taking this very serious downward trajectory, and they're altered and their GCS is down and everything is really obvious. It's oftentimes a child who spends most of their life not particularly interactive and if they don't come with a care provider, or if their care provider is unsure, then their level of consciousness is often unclear to start with. So that can be a very difficult thing to assess in pediatrics, which may be a little different than some adults. And then the contraindications to non-invasive positive pressure are also pretty similar. Alex was reminding me that in adults, sometimes you can't get a seal because of a beard or something like that. We don't deal with that as much, realistically speaking, but we definitely see anatomical barriers. So congenital facial malformations, for example, come up quite a bit, or realistically speaking, at different institutions, and depending on where you are and what your resources are, they're often, you might be sort of at a place where you can't find a mask that fits that patient's face just because of the normal shape and size of their face, but just being smaller than, they may only have adult masks. We often sort of fashion adult masks that are intended to be nasal masks over the nose and mouth and provide these seals that sort of the best we can. But I mean, those are real realities in pediatrics that we deal with frequently, is that things aren't made quite as well for children. And so, at many places you're dealing with things like that. And then looking at sort of more specifically back to the algorithm that we were working on, or that we published, our inadequate ventilation actually goes all the way down to 7.2, our pH recommendations. And you would obviously have caveats, right? Like if you have severe pulmonary hypertension, that's probably not a great choice. But for the average person coming in, children can tolerate a little bit lower pH than adults can tolerate, because their hearts are generally in better shape. Obviously, like changes in work of breathing and tachypnea, and these are very subtle and different for different age groups and different sizes, and the way that the child appears. And oftentimes you're relying on caregivers to help you understand what their baseline mechanics are like. And then once we do intubate them, and I think Alex will go into this a little bit more, and everybody on this call probably is pretty familiar with it, but we go sort of straight back to our pediatric ARDS management guidelines, which is trying to be gentle on the lungs that we know are, inflamed and trying to heal. And so, low tidal volume strategies, permissive hypercapnia. Pediatric patients also tolerate relatively lower oxygenation, and they do fine with that for the most part. And then titrating everything to effect. And we'll talk a little bit about some escalation options in just a minute.
Yeah, I think your point of really the name of the game, whether you're managing pediatric patients or adult patients with ARDS, goes back to lung protective ventilation. And again, there's been several sessions through this forum that have focused on different aspects of that. And I think to your point that this is there have been evolving protocols at institutions throughout the course of the pandemic. I think, from our perspective, we've had groups of helpers come help us in the ICU at various times. And so these protocols were helpful when you had someone who wasn't critical care trained helping you out, which was always really appreciated. And I think one of the changes has been over the course of our time was moving a little bit away from sticking to strictly the ARDSNet PEEP tables, which again were helpful if you had providers coming in. It's very algorithmic. But I think there's been a lot of discussion about patients with different lung compliance within COVID, folks who have okay compliance, then folks who have really terrible, really low lung compliance, and managing them differently. So we have really moved away from the ARDSNet PEEP tables in our unit and doing more driving pressure to determine ideal PEEP, reassessing multiple times as lung compliance may change. And one of the things we were discussing as far as ways to manage those older teens who have, for all intents and purposes, adult physiology and adult BMIs, esophageal balloon has been really helpful for those patients with higher BMIs. There's a nice best of ATS video lecture series on this topic, but something that could be potentially used in those older pediatric patients with more similar adult physiology to help figure out ideal PEEP. And then just briefly as well, as far as things we've taken away on the adult side for managing patients with severe refractory hypoxemic respiratory failure due to COVID has been prone positioning. Certainly this was something that was done pre-COVID for patients with ARDS, but I will be honest, in our unit, we didn't have familiarity with it. We didn't have that many patients at all times with ARDS where we were able to get good protocols down, because it is really technically challenging and a lot of logistics to be considered. So it's not just something you can go up and flip a patient willy-nilly. Really coming up with protocols for holding tube feeds, thinking about batching procedures before you flip someone over on their belly if they're going to need a central line, remembering that you got an EKG while they were on their belly and how to look at that EKG, and then keeping someone sedated and comfortable throughout all that has been a big learning process for everyone in our unit. The cares related to skin breakdown in different areas. Really, it's been really beneficial to our patients. It definitely has helped their refractory hypoxemia. And I think it is something our unit will continue to do after the pandemic for non-COVID related ARDS. That'll be a change going forward. But certainly was a learning experience early on that's now become more sort of run of the mill for us.
Yeah, I think in the pediatric population, we don't do this very frequently. I've certainly seen it done, but when it's done, it's a really big deal on my unit because, realistically, the less you use it, the less people are comfortable with it, and nurses are comfortable with it, and respiratory therapists are comfortable with it. And oftentimes, while the airway may not be a challenging airway necessarily, when you have a very small patient that you've intubated, for example, you don't have as much real estate on that endotracheal tube. Your 3-5 endotracheal tube, if it moves a half centimeter, could be in your mouth, as opposed to an adult airway where you have, a good 3 centimeters of play here and there. And so I think we are less comfortable with prone positioning in pediatrics.
And actually, that's a great point about the ET tube. We actually have had issues with ET tubes moving while patients were in prone positioning, not having a good sense of when to reassess with X-ray, which we don't routinely do for our intubated patients. But you're right, you have that much less wiggle room on the pediatric side with those little teeny tubes. So that's kind of some of the highlights from where the management overlaps and differs as far as the parts of hypoxemic respiratory failure algorithms with good evidence. But I'll hand it back over to Jenna now for a couple other things to discuss.
Sure. So we had, Alex and I sort of talked through this trajectory and got to the point where we were like, okay, so what if things are failing? And we'll go a little bit into ECMO after this more specifically, but I was sort of asking from a pediatric perspective, what do you guys do in adults? It seems like you are tracheing people much more frequently or earlier, certainly, than we do in pediatrics. And I think that's a general feeling, and we certainly wait too long in certain patients. I think that's accepted as a reality in pediatric ICU medicine. But we are not tracheing patients at the 7, 10, 14, 21 day mark. That's not something that we have as part of our practice. And I think it's a difference in adult and pediatric medicine. And obviously there are caveats to like things that are available to you and how your bed situations are going and where your patients are sort of in your hospital. And people are welcome to throw in the chat, at what time frame you start thinking about tracheostomies, because I think it would be really interesting to see. But in pediatrics, you really have to fail extubation at least once to be considered for a tracheostomy.
And I will say on the adult side, I feel like COVID has pushed us out farther than we typically had been comfortable with, somewhat related to concerns about infectious risk, doing a procedure too early when we weren't sure, viral shedding versus persistent positivity reflecting ongoing infection. And then just once you have a fresh trach in, proning really comes off the table, or at least feels a lot less safe to have a fresh trach that you need to support. So I do think it really has pushed us back on the adult side. And I think that's still very much an ongoing topic of discussion, but I think you're right. In general, we're a little bit sooner to trach in adult critical care.
Yeah, our threshold
probably institution dependent, but yeah.
Mm-hmm. And then we had talked about inhaled nitric oxide and inhaled EPO. We use almost no EPO in pediatrics, inhaled for that matter, sometimes other versions. But anyway, for the nitric, outside of pulmonary hypertension, there's really no evidence in pediatrics to use nitric. That doesn't mean we never use nitric. We certainly use it as sort of a Hail Mary, or when we're trying to buy some time for something else to work. So for example, we're buying time to get you to a cath lab to get cannulated, or we're buying time to diurese you or to let the antibiotics kick in or something like that. But it's sort of on everybody's radar when you are failing, but it's not something that like has a lot of evidence behind it in general, but certainly not in COVID.
Yeah, I would say same on the adult side. It's certainly, I feel like we've used it more just because we've had more patients that have been at that really refractory hypoxemic point. And maybe sometimes you're hoping you'll help them hemodynamically. If you've seen on echo, they do have more RV dysfunction. Sometimes we're surprised, but I think in general, we turn it on, we look at the gas, we say, yep, I guess not, and we turn it back off, so.
Yeah, it's tough. And then, Alex and I were also talking, and I said, oh, what do you think about the oscillator? And she was like, I don't think we have an oscillator in our hospital, which I think is obviously a difference in adult and pediatric medicine. Adult medicine has shown like relatively clearly from what I understand that it really doesn't work all that well in adult patients. I'm sure there are caveats to that, and I would love in the chat if people are using the oscillator, then it would be super interesting to put that in there so that other people can learn about it. But we do use the high frequency oscillator ventilation strategy in pediatric patients intermittently. There's not an oscillator going in our ICU all the time or anything like that, but we certainly use it. And we're pretty comfortable using it in our patients. It obviously wouldn't work in a prone patient. You have to be paralyzed, for example. You lose your ability to monitor their compliance. you risk pneumothoraces and hemodynamic instability, and you can't really clear secretions. And so there's a lot of problems with an oscillator, but at times you can re-recruit really well. And that's something that we've used it for. So I think we can go into the ECMO slides maybe. So pediatric ECMO versus adult ECMO, I took these relative contraindications off of the ELSO website, so the Extracorporeal Life Support Organization website, in one of their most recent iterations of these contraindications. And I would just pointing out that I think we're a little bit more liberal with our ECMO in pediatric patients than potentially in adult patients, although I think it's springboarded on COVID realistically. But ECMO grew out of the pediatric population. So we are pretty comfortable with ECMO in general. And we don't have, there are very few hard contraindications, at least per our, we have an ECMO sort of council that we run all ECMO population or questions sort of by as we consider cannulation. A few of them being like a prolonged out of hospital cardiac arrest. We're not going to cannulate that patient to ECMO if they've not had ROSC or, a large brain bleed, for example. But outside of those things, we certainly would cannulate a patient, for example, off this list with chronic lung disease, a NICU patient with chronic lung disease that had sort of grown out of some of that management. And we would certainly, calling a pediatric patient incurable for their malignancy is a very tough thing to actually get to with an oncologist. And so, those patients do get cannulated to ECMO intermittent leave, and stem cell transplant patients are being cannulated more and more and having, I wouldn't say great outcomes, but having some positive outcomes realistically. And so COVID patients are certainly going to get cannulated if they get to the point in the algorithm where they need to be.
And we had discussed a couple of teens. One had gone to the adult ICU just for the RSV issues in our PICU. There were no ECMO beds due to RSV recently. And so a 17-year-old went to our adult ICU, and talking with our trauma surgeons about kind of their threshold for what can be an adult versus pediatric ECMO cannulation, kind of interesting considerations. And I think it's certainly been a learning curve for all of us. I think institution specific, our ECMO, our VV ECMO is run by our surgical ICU. And so in the NICU, it's very much an ongoing discussion with our surgical colleagues. And it's been interesting for us to kind of learn about their process and who is able to go on ECMO and who isn't. But it's a really tough discussion.
And I do imagine, as Alex said, that it's very institution specific. And I mean, it's a limited resource, right? So you have only a certain number of circuits in a city realistically. So you have to sort of make decisions.
And then on the topic of ECMO, and I promise the second half of our presentation that moves outside the hospital is much more uplifting, a little bit more positive about where COVID is with pediatrics. So I promise we started with a lot of doom and gloom, but it does get a little bit brighter as we move to topics outside the hospital. But one thing that we did feel was important to highlight in the pediatric patient population was multisystem inflammatory syndrome, just because that's really been a large part of the pediatric COVID story up to this point in the pandemic. And I think we're all still sort of waiting for the hammer to drop with the Delta variant if we're going to still see a lot of that to come. But did want to highlight some challenges in diagnosis and management in the pediatric population, and also put in another plug for uses of ECMO for MIS-C. So briefly, we had a 5-year-old patient who was previously healthy who came into an outside emergency department with 5 days of fever, belly pain, vomiting, sore throat, and a new rash. She was pretty ill appearing, was hypotensive despite fluids, tachycardic, and her chest x-ray at the outside hospital reportedly had bilateral hazy opacities. Nasal swab was PCR positive for COVID-19. There weren't immediately any obvious exposures, although it came to light later. Maybe an aunt had it about 2 months ago. But she was pretty sick, requiring pressors at that point, and so was transferred to our PICU. En route, she required escalation of respiratory support as well. Here's one of her earlier chest x-rays. I'm not sure how large that is projecting on folks' screens. One of her early films upon arrival to UNC, she did require intubation. You can see those dense bilateral hazy opacities. And you can see some of her initial laboratory work here where she does definitely have evidence of inflammation as well as some cardiac strain. And certainly she was PCR positive. She had hypoxemic respiratory failure. Is this severe acute COVID? Very possibly. But there was also pretty early on a diagnostic concern for MIS-C as well. Bedside echo was performed early on that showed low normal left ventricular systolic function, but mild dilation of the left anterior descending coronary artery. So pretty quickly she got started on methylprednisolone. Her management was a little bit complicated by her severe hypoxemic respiratory failure and hemodynamic instability. They were concerned about how well she would tolerate the volume of getting IVIG as additional immune modulation for MIS-C. And she was requiring escalating pressors, high vent setting. So ultimately she was cannulated for VA ECMO after a repeat echo showed worsening cardiac function. While on ECMO, she was able to tolerate the additional fluids for the IVIG, and actually in discussion with ID did also get remdesivir just in case this was acute COVID. Again, really hard to know in the moment when you've got a very, very sick child. But the rheumatologist still felt comfortable also then giving anakinra to try to tamper down this really impressive inflammatory response. Fortunately, she did really well once on ECMO and once getting immune suppression, and was had improving cardiac function over serial echoes and was able to come off ECMO after about 6 days on, and then was subsequently extubated to high flow, and then was able to leave the hospital within a couple of weeks on room air, on a steroid taper, and on aspirin therapy. And again, fortunately, has done really well in follow-up with cardiology with normalization of her echo findings. So again, I apologize that we picked like really scary acute hypoxemic respiratory failure cases and a really scary MIS-C case. But I think the main things to highlight are this is really rare. I know this is a big concern of everyone's. It is really rare. And ultimately, most kids do really well based on the available data we have so far. Stacey, I don't know if you wanted me to cover the slide briefly or. Okay, so according to the CDC, these are kind of the current criteria being used to define MIS-C cases. Pediatricians will know that there are a lot of clinical overlap with other clinical entities in children, such as Kawasaki's disease, but also other viral infections like adeno can give you rash and myocarditis. So it's not entirely straightforward. And again, you can get ARDS, volume overload. It can be really hard to sort out from acute severe COVID in children. There was a recent publication in JAMA that did do a good job of highlighting, based on what we know so far with cases, how to maybe determine if it's more likely to be MIS-C versus severe acute COVID-19. Age can be a clue. Really, This tends to happen in younger kids, more the 6 to 12 age range. And then if you're seeing significant cardiac involvement with or without respiratory involvement, think more MIS-C, that rash or sort of mucosal changes, think MIS-C. In patients who have other underlying comorbidities, they're more of a setup for severe COVID. As Jenna was mentioning, most of those patients have had other comorbidities in the pediatric patient population, but it is really tough. And sometimes patients initially will get started on remdesivir and high-dose steroids and maybe also get IVIG if you're not sure, because there can be a lot of overlap. And fortunately, so far, based on this article, most echo findings, including coronary artery dilations, have been improving with time, but certainly this is a group that's going to need to be watched closely going forward for many years to come. And I think with that, we're coming to the end of our first part here. So I will stop sharing my screen unless anyone else had other things to jump in on the MIS-C. I think it comes up a little bit later too, but.
Alex, is this the set of slides that still has the?
Oh, yes, it does.
Vaccines? Do you want to keep sharing that part?
Yep.
Thank you. Sorry.
Now that I've stopped. No, you're fine. Let me see if I can.
So the next little section, I'll just jump in a little bit. We were going to talk about vaccines in kids, and definitely something that I have thought a lot about as a pediatric ID provider, gotten asked a lot about, both in the hospital and outside of the hospital. And I think people are, very appropriately concerned about both the population of the world, which is lovely and important, but also their own children. And I think that's really important too. And so just trying to go pretty quickly through this, since I know that we are going to bump up to the time, certainly, but the vaccines that are approved in the US, I think everybody knows, but Pfizer is the one we're really going to talk about because that's the one where there's some data that's come out more recently. So currently approved down to age 12 with an EUA, up to 16 where it's FDA approved. And then I'll go through some of these timelines afterwards. Next slide. Thanks. So people have been asking, why is this Pfizer data one back? Why is that Pfizer data taking so long? And I think, you forget in all the excitement how long it actually takes, and actually that this is a hugely expedited timeline. But essentially, they didn't start enrollment into these trials until late March. So you certainly couldn't have given these 2 doses 21 days apart until late April to May, more realistically. And then the FDA, very appropriately, in my opinion, asked for at least 4 to 6 months of safety data with adverse event reporting. And in adults, they expedited that with 2 months of data, but in pediatrics, they asked for more. And I think that's super important. 26% of the world's population is under the age of 15. So before we vaccinate the entire, future generations of the world, let's find out if there are any adverse effects from this vaccine, which seems to be a miracle vaccine and effective and safe and all these things. But it's really important. People obviously always take pediatric studies into sort of closer scrutiny. And then in addition, as we've, it doesn't seem like it from our presentation, but as we all actually know, pediatric patients do well from this. So we have the bar for vaccinating them is a little higher. And so finally on September 27th, they released some of their data to the FDA. It's not their final data, but a lot of their data to the FDA. And then it was more formally submitted. And so it has not officially been submitted for EUA sort of by the EUA guidelines, but it has been submitted to the FDA for early scrutiny, which is great. Next slide. This is some of what they found. So they released this to the public. These are just headlines from the studies, essentially, but around 2,300 children were enrolled. This is the 5 to 10-year-olds who received this 10 microgram dose, which is a little smaller than the doses that Moderna is testing. And I'm going to skip those slides, so I'll just point that out. But the neutralizing antibody, which is what they've been looking for, has a geometric mean titer that was around the same as their control dose, which was the 6 to 25-year-old age range. Now, that doesn't mean much realistically, because we still don't know what the titers mean. We don't know what the protective level is. We don't know, who responds and why, and is this 20 times the protection level? Is this 5 times the protection level? Is this right at? Very unclear. And how long those levels last, still a little unclear. But it does seem from outcome data that this level has worked in the 16 to 25-year-old age range. So we think it is probably likely to work in this lower age range as well. And the side effect profile seems pretty similar. Next slide. And then I'm going to skip these Moderna trials, but essentially they're doing an adolescent and a children's trial as well. And they're sort of multi-armed studies that are going to take a while, and they're a little bit behind Pfizer on their enrollment. Not that people aren't eagerly driving their children hundreds of miles to be enrolled in these studies. But looking at the side effects, which I think lots of people want to know about, I basically tell everybody that asks me that, yes, you're going to have a side effect. That is your body's normal response to building immunity. And you have side effects from every other vaccine you get to. There are, a range of side effects from every vaccine. So we tell people the most common side effects, which I'll go through in a graphic in just a second. And they usually occur within the first week, but most commonly within the first 1 to 2 to 3 days. Next slide. And so I think this is a great infographic that you're looking at. The top two panels there are injection site reaction at the first dose, injection site reaction at the second dose. And then the bottom two panels are systemic reactions to both the first and the second dose. And so you get a sense that you're probably going to see with that second dose quite a bit of fatigue and headache and chills. This is 40 to 65%. And you may even see some actual severe fevers in 2.3%, and severe fatigue and severe headaches, definitely muscle pain, but nothing that's sort of beyond the ordinary for these types of side effects. And I think warning people ahead of time what they might be expected to see, and posting something like this in your clinic is very realistic, so that parents can know what to expect. But if you compared these to other pediatric vaccines, you're going to see similar pain at injection site. You're going to see similar fevers or headaches or lethargy following the vaccine. Next slide. And then what people are very worried about, which is super appropriate, are rare but serious side effects. And I think, I point out that there's an anaphylactic risk. It's very low, 2 to 5 people per million people that are vaccinated. So that's not very many. We've vaccinated 400 million doses. That's not to say 400 million people, but it's not that many people that are having anaphylaxis to it. And they're mostly being vaccinated in places where they can be monitored and treated for such. And then Guillain-Barré, as well as the thrombosis with thrombocytopenia, have really only been seen with the J&J vaccine. And that's not yet approved or anywhere near approval in pediatrics, so I'll skip that for now. And then the myocarditis and pericarditis picture, which I think is more concerning, or at least that's garnering more concern from people. Next slide. And so looking at that, it's really associated with the mRNA vaccines. And with young males that are getting those vaccines. And so we'll go through the numbers in a second, but it's usually within a few days of the second dose, and almost everybody totally resolves. Those are sort of the main points. And then we tell school nurses, we tell parents to look for chest pain, shortness of breath, palpitations, and then we tell, emergency department providers and or primary care doctors to look for ST segment changes and troponin elevations, things that you would see with myopericarditis. Next slide. And so when they looked at the actual numbers of these, they being the CDC, and following the vaccine adverse event reporting, I think what is important to note is that they were mostly saying myopericarditis and very much less pericarditis by itself. The median age was again that sort of young male range, or young range, but also 72 to 82% male, and usually very close to that first or second dose. And then I find this second bottoms part of the slide to be the most useful sort of comparator, the way you think about it. But it helps you see that sort of within the 7-day risk period after you get that second dose of the vaccine in these different age ranges, that is the cases of myopericarditis that you would expect in any population, which, because of course it exists with other viruses or with autoimmune disease or things like that. And then the cases that they were actually seeing in the vaccinated population. So the first part there is females, and you see that it was definitely higher in that young age range, but you really see that jump in the males. So the 12 to 25-year-old range is pretty significantly higher. And this is what people have been worried about and talking about. Still very low numbers altogether, but that is a much higher than expected. So certainly associated to some degree. Next slide. And then outcomes after this. So 700 or so were hospitalized. Most of those have been discharged already, and 18, and most of those totally recovered of those discharged. And then 18 were still hospitalized. A few of those were still in an ICU and like relatively ill still. And so all of this data together prompted the CDC to change the vaccine adverse event reporting system from being sort of a very passive system, which it has always been, into a system that in this particular case was more active. And so they reach out with surveys to determine like functional status and things of people that have had adverse events. And I think that's actually like a very large change in our VAERS system. But it means that there's going to be good data about this and that they're paying very close attention. And I think it should be reassuring to those of us that are encouraging young people to get vaccinated. Next slide. And then just reporting adverse events, saying this more specifically for everybody that gives a COVID-19 vaccine, not in someone's backyard, but like, in an actual facility, they are mandated reporters of any of the following events. So you can feel reassured to know that vaccine administration errors, whether or not they ended up doing any harm, get reported. Serious adverse events, no matter whether or not it's related to the vaccine, gets reported. Cases of multi-system inflammatory syndrome in adults or in pediatrics get reported. And then any COVID-19 that results in a hospitalization or death gets reported as well. So they're watching very closely. And I feel reassured by that. And I use this as reassurance for people that are having vaccine hesitancy issues when I'm talking to them. I think that's it on the vaccine slides.
Thank you, guys. I know we were going to save questions till the end, so maybe we'll just move on to our next speaker. So our next speaker is Dr. Stacey Peterson-Carmichael, whom I know very personally, and I'm so thankful that you're here today with us, Stacey. Dr. Peterson-Carmichael did her training in multiple fellowships, just like Dr. Shah was saying earlier, in pediatric pulmonology and pediatric ICU. Currently, she is the division chief for pediatric pulmonary at Atrium Health, Wake Forest Baptist, which is Brenner's Children's Hospital. She has particular interest in sickle cell disease, lung function measures in children, flexible bronchoscopy, and clinical program development. So thank you so much for joining us today, Stacey. And just a reminder to everyone who's on the call, please, again, feel free to type your questions in the chat. I've been typing some of my own, or write them down, or direct message me and I'll ask them for you. So go ahead, Stacey.
Great, thank you. Thank you very much, everyone who's joined us today. So I'm kind of the closer for this group. We've gotten all this hard data from Jenna and from Alex. So this is going to be probably more applicable to those of us maybe who are parents. I'm going to try to represent, I am not a general pediatrician, but they are really our frontline workers right now. So this slide here, I think we probably have all seen this at our hospitals in terms of percent of hospitalized and ICU patients were vaccinated versus unvaccinated. So I'm going to start just throwing these cards around the hospital. No words needed. Oh, it's not 4A. Oh, Lauren, if you're there, if you can, I can't get, there we go. So main questions that Sushma and I thought that might arise from this, just to touch base on. So Delta variant, is it more contagious? I think we have pretty much addressed this, and the answer is yes. Does it cause more severe disease in kids? I have a couple of slides relative to that. Is in-person school too risky? I think that's a family decision, but I think I have some reassuring information on that front. And what are masks doing to our children and for our children? A lot of people feel like children shouldn't wear masks and they can't see adults' facial expressions, and it affects their development also. And then the mental health effects have been significant with pediatrics alongside adults. And I think that's a big concern for us as pediatricians, but also as parents. So for those who want to go ahead and leave and go have dinner or whatever, I'll give you kind of the synopsis of the next few slides, and you can come back. in general, we just need more longitudinal data. We just don't have it for outcomes or for the lingering effects. I mean, we don't have enough in adults and we have very little in pediatrics. I think the educational, psychological, and emotional effects are not known, and they may really be longstanding in children. I think most of us as parents, pediatricians, or that horrible combination are still unsure of, a lot of very scenario specific risks. I know I struggle with this weekly, if not daily. We can all have discussions about that, different social events at school and field trips, et cetera. I think for us, when we're counseling our families and our patients, I think it's a real balance, and we have to use what data we have, but respect potential emotional side effects of isolation and what the family values are. So in general, what we all agreed about is that we just need more PED sessions like this moving forward, because this is too much for just one session. Okay, so for kids, risk factors for severe illness. So there may be a lot of chatter about this, but really the data is pretty limited. Obesity, I think we can say there's a strong signal there, just like there is for adults. Asthma, interestingly, there's more of a signal in peds than in the adults that it's a risk factor, but there's a lot of conflicting papers that some say it is more of a risk factor and others not so much. Diabetes and pre-diabetic states, we see that, immunocompromised. And then interestingly, other forms of lung disease, really there's not as strong of a signal to say that this is a very strong risk factor for hospitalization should our children be infected with COVID-19. So the data, this was of last week for ages 0 to 17, and this really represents, a little less than a quarter of our entire population. So, if you look at the percent of total weekly cases, again, this is kind of over the last couple of months as Delta has been emerging, we've really gone from, about 15% to more like 26%. So far, we have almost 6 million infections with children. Hospitalizations, if you look at what percentage of hospitalized patients are children, it has gone anywhere from almost 2% to 4%. And then the percent of pediatric cases that end up being hospitalized, depending on area of country or what data you look at, can be almost 0% to up to about 2%. The good thing is in terms of mortality, I think as Jenna was kind of touching on, it is very low. We all consider any death due to COVID in a child, a terrible event and potentially, could we have prevented it? But in general, some list 0%, depending on how many decimal points, up to about 0.03%. And then I will break it down a little bit based on age, because that does matter. School transmission, this is the good news, very low if there are protocols in place. And then, long haul COVID or whatever you want to call it, whatever it will be in pediatrics, there's really not much data on this. Some I looked at from 11 to 14%. And then interestingly, if you look even at lung complications after COVID, it depends. Some only follow up to 3 months, some have followed up to 6 months, and the percentage is actually not that high, which, as a pulmonologist is reassuring. So are kids less affected by COVID? So I think this has been, again, lots of conversation about, yes, kids are great. We all love our kids, but really, is it that big of a deal in kids? Why are they doing so well, right? Because usually with flu, we get a very U-shaped curve, depending on the flu season and the variant, right? Usually the very young and the very old get affected. This has been very different. We don't think kids are more vulnerable with Delta versus other variants. People thought initially, well, kids just aren't getting infected like adults, and that we're seeing is not true. It may not be exactly equal, but they really are getting infected almost as often, tend to be ages 10 and up, tend to be more likely to be infected than under 10. But the most important message is way more kids being hospitalized right now with RSV and other viral infections than COVID. So those of us, whether we're hospitalists, pediatricians, pulmonologists, whatever, this is our burden right now. And there's a lot of co-infection, which is interesting because early on, people did not focus on that. What happens if you get RSV and COVID or rhinovirus and COVID? And there's a lot of that right now. I don't think there's any data, but I think we will know in the next 6 to 12 months that probably those kids are more seriously affected just from kind of case reports. So what are the possible mechanisms that kids in general seem to be more resilient? Some are saying, do they have fewer ACE2 receptors? Is that why? And that's one way that the COVID-19 vaccine actually gets into the respiratory tract epithelium. reduced adaptive immunity or neutralizing antibodies, because potentially this is the mechanism by which we get a lot of the horrible side effects of COVID, especially in the adult population, and potentially just because they have better innate immunity. So this is a curve, and I apologize, of course, this changes like day to day. So this, I've kept most of my slides and updated some of them. But the point here is just obviously the kind of gray blue, this is the adult population, the red is the pediatrics, and the proportion is, you know, alarmingly more adult than pediatrics, but just looking at the difference of number of new cases, that really we almost doubled number of new cases. So I think that's why, in addition to it being having a resurgence of RSV, and goodness, you know, we don't even have flu yet, we have had, you know, overwhelmed ICUs and hospitals, and for once, fear of the adults having to actually come work in the peds ICU versus the other way around. This is, again, just breaking it down by age. Again, the red curve is showing kind of 65 and above, that at-risk population, which we've seen for, you know, over a year. And then again, these little lines near the bottom are younger 0 to 4, kind of 5 to 17. This is a slide, I stole this one from Jenna, so she can speak more, especially in the question category about BPS. This is a great database system for PEDS ICU, and probably will give it a lot more data than probably any other source for COVID in the hospitalized patients. So I think it's, you know, a little bit just looking, as they were discussing, I think Jenna got this data, this is from March, so this is early 2021, but looking at a lot more conventional ventilator than high flow. So potentially if we looked at this data now, you know, that may be reversed or a little bit more equal. And then comorbidity here, I'll show normal about 40%. I have a slide that shows something similar versus those with mild or severe comorbidities. And then of course the age distribution. And then pointing out, you know, we do take care of adults. Here's up to 30 years. This slide, it's hard to see, but again, it's just showing the proportion of the population that is a certain age range, and then the percentage of deaths from all of COVID attributed or seen in that age range. So you can see here 0 to 4, 5 to 11, really getting into the teenagers. I mean, you can't even hardly see, it's less than 0.1, 0.1, 0.1, you know, when we get 18 to 29 kind of young adults, it's 0.6% of the deaths. Again, this may change, you know, in the upcoming 3 to 6 months, but again, it's very rare, you know, there are not that many deaths that have been seen in the pediatric population. Here, I think showing here, this is kind of a U curve, because when you look at, this is mortality, looking at deaths per million. And if you see this red curve, that's kind of the highest rate here in less than a year. So our neonates. And then again, looking at our older population, our older teenagers. And I think those of us who see patients in the hospital, that is very much what we're seeing, that we see very sick neonates, more the teenagers, and then that kind of middle school age, not as much, even those that are not vaccinated. This slide I thought was interesting, and a lot of these are CDC, so you can't see here from the CDC website. And I just put orange arrows here just to show what we think are signals in terms of comorbidities and increased risks or percentages of hospitalizations for those who have COVID. So over here is asthma, and sorry, the blue bar here is adult, and then the light blue bar is pediatrics. Red is pregnancy, and we won't be addressing that today. But here, there's actually more of a risk for pediatric asthmatic patients than in adults for hospitalization if you are infected with COVID-19. This, I think, is interesting. This is other pulmonary disease. I don't know all of what encompasses this category, but really not as significant for pediatrics. Which is great, right? For me as a peds pulmonologist. And I have seen this. I have seen kids with FEV1s of 20% who came in when I was on call with COVID. And I thought, this is it. This is the end. And 3 days later, they were home. So it is, kids are amazingly resilient, even if they have poor lung function. Obesity, I think we're definitely seeing here, more significant in the adult population than peds, but still, you know, pretty significant. That's 34% listed as at least one of the comorbidities in hospitalized patients. But again, when you go over here to really normal or no condition, that is the most common that is reported at over 40%. I also stole this slide from Jenna. So this is masking for children. I will add some of my own data in here, but I think it's just a nice visual. And really what it's saying is that in general, are masks helpful? Yes. You will get people who will debate that it's not, or it only minimally prevents it. But if you use an appropriate mask in addition to other mitigating factors, I think is what you'll see on the CDC website, that masks are absolutely helpful in decreasing risk of infection. Then we hear this a lot, in addition to vaccine hesitancy, that they either don't want their children to wear masks, or they don't want teachers and others wearing masks around their children or infants in childcare because they're worried about decreased socialization, delayed speech, and development. And in general, as far as I know and what I've looked up, there's no evidence that that is the case, especially if people focus on, providing interaction, communication, reading to your child, et cetera, without a mask on at home, using FaceTime, et cetera. So masking in school. So there are multiple epidemiologic studies in this. I took this one. This is a recent one that was in the Mortality Weekly Report from the CDC. And this was looking at 2 counties in Arizona, but it was almost 1,000 different public schools. And so what they looked at is the outbreaks, which again, the definition is different looking at every epidemiologic study, but what is the risk associated with schools that enforce mask mandates as an expectation before school started versus those that switched to that requirement after school had started, versus those who had no mask requirements. So essentially, schools who did not have mask requirements or mandates had 3.5-fold increase in outbreaks compared to those that did not. So I think that's great news. So out of those outbreaks, 191, 16 were in those schools who established the mandates before the start of the school year. And this is only looking at about 1 to 2 months of data. 62 were for schools, school systems that were implemented after school had started. And then the largest majority were those who had absolutely no mask mandates. Now, I think if you look at the COVID website, and again, I think I do this more as a parent in terms of looking at what the CDC has recommended for schools, and then of course, comparing to my schools to see what they're actually enforcing. What they're saying now, which is a little bit different than what they said a few months ago, is that they are saying that indoor masking is recommended and should be done for all children ages 2 and above up through high school, regardless of vaccination status, as it applies to kids 12 and older. Vaccinating all eligible staff and students, of course, that's very controversial. I think everyone on this call would agree that that's really important. Screening and testing protocols, which as a parent, I have found, and a provider, the most frustrating, because not only does it vary from state to county, even within one county, each school can have a completely different screening and testing protocols. And if I can yet again give a shout out to the general pediatricians, that they are dealing with every sniffle, rule out COVID, every school has a different rule. I mean, it is really stressing those practices. Improving ventilation in school, this is a little more vague. I don't know what to do. I mean, I just kind of tell my kid, my oldest child, like, make sure your window's open when you're on the, if you're on the school bus for a school trip or something. I don't know what to say about that. People want to bring in their own HIPAA filters to school. I don't know that there's a lot of data on that, and then of course, avoid crowding and physical distancing. And let me tell you, every school has their own ideas about that. They say it's 3 or 6 feet, but then they have these little pods of desks all together and they're eating lunch. So that's probably not really physical distancing. Here, this is a very simple slide, but just wanted to really point out for pediatrics that not only are we also seeing healthcare disparities as with adults, but this has really been highlighted, especially with food insecurity, especially with obtaining healthcare and vaccine allotment, mental health and development, which I'll touch on a little bit. And then I think for every single person who's on this call and basically everyone on the planet, how to balance family, work, and childcare, either last year or this year, and moving forward. And then something a little bit more specific to pediatrics is really increased cases of abuse and trauma. So another group of my colleagues that I feel for is our Child Protective Team services. So COVID-19 and violence against children, this is really just from reaching out to my colleagues, and they thought this was probably the best article, which was a review of 48 different papers and reports. For naysayers, this is not all peer reviewed. This is, just reports and whatever information they can get. Obviously, this information is difficult to obtain, but what they found is when defining violence as either physical maltreatment or abuse and neglect, they included bullying, youth violence, so kind of violence of youth on youths, sexual violence, and emotional and psychological violence. For this paper from Child Abuse and Neglect, they basically found a decrease in police reports and CPS reports, which is a little disturbing. And then really mixed results on whether there was an increase or decreased number of just calls to police or helplines. They did demonstrate an increase in child abuse related admissions to the hospital. And I know at least at our center, we have definitely seen this. I'm not sure about others on. And then surveys just reported definitely, increase in family violence. And so I would say, I don't obviously believe everything on the news, but I think what we're seeing definitely reflects what's truly happening in many of our households. So another thing that I'm not quite sure how often you all speak about in the adult world, but we try our best to address food insecurity, but then also obesity, which as we see is a risk factor for severe COVID. And in pediatrics, these interestingly often go hand in hand. And so this article from Current Obesity Reports I thought was really interesting. They looked at just that week in April of 2020. And in that week, approximately 35% of households with children did report food insecurity, whereas just a month previously, it was only 11.6%. So I think this is really dramatic. And obviously is magnified by dependence on meals at school and childcare centers. With respect to obesity, again, our general pediatricians, I think, are seeing a dramatic increase in BMI as a whole and with individual patients. And I think, especially last year with schools not all being open, it was a little bit of a summer vacation schedules. This is not to diminish, how stressful it was, but just a lot of lack of structure, which goes with increase in obesity or excess weight gain in summers that we see in the obesity literature. And some of it may be, not with all, immediate availability of snacks, more screen time, less activity. And then again, we see the socioeconomic disparities of a lot of our families who live in poverty have a lot less access to physical activity. And this was even worse with playgrounds, et cetera, being closed. So conclusions, it's good news in general. Children, even unvaccinated, are still they're at risk, but lower risk. The majority will do well, but we don't know the post-infectious complications. So I think I speak to that to my parents of children who need to be vaccinated and to the children that even if you don't end up in the hospital, we don't know, any of us could lose our job, as side effects of having COVID. So just to think about that, or who's going to take care of your child if something happens to you. There has been a dramatic increase in the number of orphans in the last year because of COVID. And the Delta variant is more infection, but I think, vaccination is going to happen. It's going to help. And again, huge shout out to our general pediatricians. I don't know if any are joining us today, and they're really on the front line, always seeing the sick kids, triple booked, doing all the COVID tests. And so I'm very thankful for everything they've done too. That's all.
Thank you so much, Stacey.
You're welcome.
Does anyone have any questions for our speakers? Feel free to unmute or type them in the chat. I know we're over time, but we can probably just take a couple of questions if anyone has them. While they're typing, I have a couple, but I'll start with one. So, given that and it's nice to hear because I think most of us have heard on the news, social media or whatever, pediatric hospitals are full, Delta is infecting lots of kids, and it just, as a parent, it all just sounds very scary, but knowing that the incidence is low, like you pointed out, and that mortality is still very low and hospitalizations are really low, how do you reconcile that with parents who are worried about vaccines? As far as, well, if it's not that bad for my child, then why should I vaccinate them against COVID? I'm just curious to hear, I'm sure you've heard that from people, like what your thoughts are and how you address that.
Yeah, I'll let Jenna. And again, to the poor general pediatricians who deal with vaccine hesitancy every day, all day. But yeah, I don't know, Jenna, kind of how you address that with families.
Sure. I think it depends on why they're hesitant, of course. But I remind them that realistically, most of the things that we vaccinated against now are both life-saving and rare, which is great, maybe aside from like strep pneumo or something like that. But, we don't see, for example, very much diphtheria or something like that. And we vaccinate against flu regularly, even though our flu vaccine, has quite variable utility against flu depending on the year. And that people feel confident and comfortable with vaccines in general. And while the while the timeline was expedited, this vaccine has shown itself across most reputable sources to be incredibly effective, even more so in this age range, so that like the effectiveness level in that sort of 12 to 16 age range was even better than adults against severe COVID. And that anything, I talk to people about anything that we can do as a society to sort of help mitigate the spread of COVID and help reduce variant possibility is also incredibly useful. So any person that gets infected with COVID is a risk for a new mutant variant. Not that they're doing anything wrong. There's nothing, that's just what viruses do. And that they could potentially harbor something that could create lots of problems. And so the way that we improve that is by decreasing COVID, transmission in general. And we do that by vaccinating children. And I've definitely been asked more than once, but like my kid is like, is not going to get it because we're super careful. And, even if they do, they'll be fine. And I can't tell you that your kid is going to get it. And I can't tell you that your kid isn't going to be fine. But, I can tell you that as a community, like we depend on each other. And that is how we're protecting ourselves and the people around us, and particularly like the elderly or, the immunocompromised population, and then against that variant too.
Yeah, no, I hear you. I mean, I'm sure the people on this call aren't feeling that way, but I'm sure we've all fielded phone calls from family and friends and neighbors and relatives. And so I was just curious your take on that.
Yeah, I agree. The primary care doctors, as well as the school nurses, I always wrote that in the chat. School nurses help them, are experiencing this every day. And the protocols in our hospitals are changing all the time. And, we've all kind of been bobbing and weaving with that. Can you only imagine answering all the parent questions as that changes in your school? No, thanks.
Well, I don't see any questions in the chat. I think so. Since we're over time, I'd just like to thank you guys again. It was a really great session. It was jam-packed full of information. So I'm sorry we gave you such a broad topic, but you covered it beautifully. So thank you again for taking time out to be with us today.
Thank you for having us.
Thank you, guys.
Thank you all.
Always happy to do anything for ATS.
Now we know, Stacey.
You know me.
I know. Well, thank you guys again. And thank you to our audience for joining us today. Have a good rest of your evening.
Bye. Thanks, Alex. Thanks, Jenna.
Thank
Thank
you
you
all.
guys. It's great.